Iota two-step strategy. After the introduction and before we conclude, we look at how to use the two-step strategy to estimate risks of malignancy in ovarian tumors. We have just one learning objective, and this is to know how to apply the two-step strategy in clinical practice. All the images for this presentation were cases we managed in University Medical Teaching Hospital and State Specialty Hospital Maiduguri. This paper, published last year, described the two-step strategy, and the clinical implication of this work was that the two-step strategy is suitable for clinical use. It went further to say that a large proportion of adnasal masses can be classified as benign by the modified benign descriptors without computer support. For the remaining masses, malignancy risks can be calculated using ADNEX. An ADNEX calculator is available online and as an application for smartphones and is embedded in many ultrasound machines. This was just last year. Unfortunately, if you go to the Iota website, you will encounter this depressing message: model unavailability from Iota. The Iota ADNEX model is no longer available because of the new regulation by the European Medical Device Regulation, which stipulates that the ADNEX calculator is actually considered as a medical device and therefore has to undergo some form of certification. But the authors were quick to add that please observe that it is not the ADNEX model itself that is questioned and needs certification. The ADNEX model has been externally validated on thousands of patients in different countries and settings and has been shown to have excellent ability to discriminate between benign and malignant lesions. So the issue has to do with the calculator, not the model. Now, looking at some basic reminders, not definitions, just as reminders, so that we follow fully the subsequent slides. When we say a lesion is hyperechoic, what it means is that it reflects beam completely and it appears white, like this femur bone. In the adnexa, what we see appear as hyperechoic could be dermoid. Here, it's bone in dermoids. When the structure is described as mid-echoic, it's like the echogenesis of the myometrium, the liver, the spleen. The urinary bladder, the gallbladder are considered as hypoechoic or anechoic. Generally, when we say that the structure is anechoic, what it means is that it absorbs beam fully without reflecting any. Acoustic shadow is seen when a structure replaces beam almost completely. Here we can see this fat ball in a dermoid. This reflects beam almost completely, and therefore the area beyond the structure will not be seen. So the area beyond it appears dark. Similarly, here we can see a case of cyst adenofibroma, replaced beam, and the area behind this is not seen. The same thing with this case of suspected fibroma. By the way, these are the three structures in the ovary that gives acoustic shadows. Don't worry. This is the fibroma and fibroma. True transmission or distal enhancement is a white band seen behind cystic structures, irrespective of whether it is normal or abnormal. This is the urinary bladder on transvaginal ultrasound scan. This white band seen behind the urinary bladder is called distal enhancement or true transmission. This is a case of dermoid cyst. You can see this white band behind the dermoid cyst. This is a case of Napoleon follicle. You can see this white band beyond the follicle. This is a case of hematocolpus. Because blood is fluid also, you can see this white band behind it. White band behind structure help differentiate between cystic and solid components. Only cystic structures give this white enhancement. So when a white band is seen behind a solid structure, that solid structure contains some cystic areas. This is an anechoic cyst, while this is a hypoechoic cyst. So I would expect that the distal enhancement from this cyst will be more than the distal enhancement from this. Why? Because here the beam is absorbed completely, while here some of the beam will be reflected. And so the distal enhancement will be more pronounced here than in this case of hemorrhagic cyst. This is an early gestational sac. The gestational sac contains fluid. So because of this fluid, you can see this white band, the distal enhancement. Beyond this is pelvis dilatation. Beyond that, you can see this white band called distal enhancement. Now looking at the modified benign simple descriptors. The modification has to do with the size. Before now, only benign simple descriptor 3 has size attributed to it less than 10. With the modified benign simple descriptors, all the lesions must be less than 10 centimeters. The risk of malignancy with modified benign simple descriptors is less than 1%. And if a benign simple descriptor applies to a tumor, it is almost certain that the tumor is benign, as you can see, over 99%. So, looking at benign simple descriptor 1, is a unilocular cyst with ground glass echogenicity in a premenopausal woman, less than 10 centimeters. This is suggestive of endometrioma. Benign simple descriptor 2 is a unilocular cyst with mixed echogenicity and acoustic shadows in a premenopausal woman less than 10 centimeters, suggestive of benign cystic teratoma, hypoechoic, hyperechoic, mixed echogenicity, acoustic shadow. Benign simple descriptor 3 is a unilocular cyst with anechoic content and regular walls less than 10 centimeters, suggestive of a simple cyst or cyst adenoma. And benign simple descriptor 4, all unilocular cysts with regular inner walls less than 10 centimeters, as is seen here. Now, why is it important that only unilocular cysts is considered in the benign descriptors and its modification? This is because when it is a unilocular cyst, the risk of malignancy is less than 1%. And that is why benign simple descriptor apply only to unilocular cysts. Once you have multilocular cysts, look at the risks of malignancy. When there is a solid component, the risk of malignancy increases. Now the other two-step strategy is that first of all, you apply the modified benign simple descriptors. That is the 4 benign simple descriptors when the lesion is less than 10 centimeters. When the benign simple descriptor apply, it can identify up to 40% of adnexal lesions. Why they don't apply? Then you now use the adnex model. So this is the Iota two-step strategy. A three-step strategy has been described and externally validated, where you start with the benign and malignant simple descriptors. If they don't apply, you move to the simple rules. If they don't apply, then you use an expert to subjectively assess the lesion. But in that case, you need an additional sonographer to do that. But in this two-step strategy, a single sonographer should be able to classify disease without the need to involve an expert to do that. So let's look at some case examples of the modified simple descriptors. This is a unilocular cyst with ground glass echogenicity in a premenopausal woman, less than 10. So you see that? So this is suggestive of endometrioma. Do you need to apply the Adness model? No, you don't, because the modified simple descriptors has actually classified this as benign. This is a local cyst with mixed echogenicity and acoustic shadows in a premenopausal woman, less than 10 centimeters. This is suggestive of benign cystic teratoma. Does the modified simple descriptor apply? Yes, it applies. Do you need to use the Adness model? No, you don't. This is modified simple descriptor 3, a unilocular cyst with anechoic contents and regular walls less than 10 centimeters. So you see, or a simple cyst or cyst adenoma. Actually, this turned out to be a cyst adenoma in a 49-year-old. So does the modified benign simple descriptor apply here? Yes, it does. So there is no need for Adness model. This is a unilocular cyst with regular inner walls less than 10 centimeters. So does the benign simple descriptor apply here? Yes, it applies. So do we need to use this Adness model? No, we don't. Look at this cyst. Does the modified simple descriptor apply here? Well, these are surgical specimens. It doesn't apply. Why? Because the size is more than 10 centimeters. So, Adness model should be used in this case. The final diagnosis was emissionous cystadenoma. Does the modified benign simple descriptors apply here? Yes, this is simple because its content is clear, regular walls, but it is more than 10 centimeters. And so the modified benign simple descriptor cannot apply here. So what do? You apply the Adness model. Final diagnosis here was serous cystadenoma, and you can see the size here. What of this case? This is a solid ovarian lesion, which turned out to be a benign Brenner tumor. Can one apply the modified benign simple descriptors? No, because this is not a unilocular cyst. So benign simple descriptor will not apply. So you now move to the Adness model. What of this cyst? Will a modified benign simple descriptor apply or not? Yes, it will. Why? Because this is a unilocular cyst with regular cyst walls. What we see here is blood clot and not solid tissue. So benign simple descriptor will apply. So there's no need for Adness model because this is a unilocular cyst, not a unilocular solid cyst. It is a unilocular cyst because this is not a solid lesion, but blood clot. Now look at this. clear content. Look at this projection here with the acoustic shadows. Look at some projection here, casting shadow. Another one here. This is a surgical specimen and the internal wall of the cyst. So will modified benign simple descriptor apply here? No, it will not. Why? Because this is a unilocular solid tumor, not a unilocular cyst. It turned out to be a cyst adenofibroma. So use the hardness model. So if modified simple descriptors do not apply, use the Iota hardness model. What is it all about? The hardness stands for assessment of different neoplasias in the hardness. It is a multi-class model. First, it differentiates between benign and malignant lesions. Secondly, it subclassified the malignant groups into borderline, stage 1, stage 2 to 4, metastatic, and thirdly, it assigns risks. There are 9 variables in the Iota hardness model. 1, 2, 3 are clinical variables. Age of the patient in years, oncology center, and the serum C125, which is optional. For items 2, 5, 7, and 8. 2, 5, 7, and 8 is either a yes or a no. And then you have 6 ultrasound variables. What are they? Maximum diameter of the lesion, maximum solid component, more than 10 locules, number of papillary projections, acoustic shadow, and ascites. And then the clinical, the age of the patients, the oncology center, and the CA125, which is optional. Altogether, 9 variables. Now let's look at the ultrasound variables. Maximum diameter of the lesion, like this, in millimeters. Maximum diameter of the largest solid component, in millimeters. More than 10 locules, yes or no? The number of papillary projections, none, 1, 2, 3, or more than 3. This is a schematic diagram of a cyst with papillary projections. So this is the cyst wall, this is a papillary projection, and this is how the papillary projection is measured. If it measures more than 3 millimeters, it is called a papillary projection. If it is less than that, it is a wall irregularity. Once there is either a wall irregularity or a papillary projection, the inner wall of the cyst is considered irregular. Now, when the indentation between two papillae is less than 50%, it is considered as one papillary projection. When it's more than 50%, it's considered separately. Now, let's look at this lesion with this papillary projection and decide whether it's 1 or 2 papillary projections. So these are 2 papillary projections. And how to measure the papillary projections? This way, excluding the cyst wall. Acoustic shadow present, yes or no? Ascites, fluid outside the pouch or outside the pelvis. Now, when one imputes all these information, the variables, and please calculate, this is what appears. Like in this case, I've imputed all this information without imputing CA125. And what pop up is this dialog box. Are you certain that CA125 is not available? The field is indeed optional, but this will decrease the discrimination between stage 2 to 4 invasive tumors and the other malignant subtypes. If you click yes, it will display the results. And this is how it is color coded. Risk of borderline, risk of stage 1, stage 2 to 4, risk of metastatic cancer, and chance of benign tumor. Now let's look at some case examples. Case 1 was a 17-year-old student who had laparotomy in a peripheral center and was referred after symptoms recurred. She presented with progressive abdominal swelling and weight loss. You can see this tumor is a solid tumor, and therefore benign simple descriptors will not apply. So we applied the darkness model, imputed all this information. So you can see that it has differentiated this tumor between benign and malignant. You can see the percentage, 88.6%. The percentage of benign and malignant should add up to 100%. So first, you can see it has differentiated the tumor between benign and malignant. Then it has now subclassified into borderline, stage 1, stage 2 to 4, and metastatic. And then thirdly, it has given the risks. So what is important here is to look at the one that has the highest relative risk. So which one has the highest relative risk here? 4.1, that is stage 2 to 4. So ARNES has classified this patient as having malignant tumor, which is stage 2 to 4. So the patient had surgery, and the finding was a yolk sac tumor. Actually, it was stage 4 disease. Case 2 was a 31-year-old single lady. She presented with a history of abdominal pain of 2 years and abdominal mass of 3 months. Her CA125 was 40. So look at this lesion, solid lesion here, ascites, obvious capsular rupture here, transabdominal, and this is the uterus here and the lesion pushing the uterus up. So we imputed all this information, and you can see it is differentiated between benign and malignant and the different subtypes. And here we look at the relative risk. The highest relative is 5.7, which is for metastatic lesion. Now let's pay particular attention to this chance of benign lesion. Note that here there is no acoustic shadow. So in the same patient, when I click acoustic shadow as present, you observe in the next slide that there will be a change in this chance of benign lesion with a decrease in chance of malignant lesion. You see that? This is because I added acoustic shadow. Why? Because there is a shadow here. But why I brought up this is to draw our attention that this is not what we are looking for as acoustic shadow. This is edge shadowing from these cysts within this solid component. As you can see, because it's a cystic structure, you can see this distal enhancement here. So what you see at the edge here are edge shadows. So this is not acoustic shadow. So this should not be imputed as acoustic shadow. If that is done, you can see the consequence. So this patient could be managed as a case of benign, while in the actual sense, this patient has a malignant lesion. So again, look at how the relative risk has changed. So the patient has surgery, and the finding was a mucinous papillary cyst adenocarcinoma. Case number 3 was a 50-year-old gram multipara who presented with abdominal swelling of 1 year and abdominal pain of 4 months. Look at the lesion. Multilocular solids, lesion with a close score of 4. So we imputed all this information on the Asner model. So you can see that the risk of malignancy is 82.5%. And look at the sub classifications with the highest relative risk of stage 1 disease, as can be seen here, 5.1. So she had surgery and there was an adult granulosa cell tumor. Truly, it was a stage 1 disease. Case number 4 was a 43-year-old gram-multiparous woman who presented with a 2-year history of recurrent low abdominal pain and abdominal swelling a few months. Now look at this solid lesion here with shadowing, ascites. So the information was imputed into the ADNES model, and this is what we have: chance of benign, chance of malignancy, and the subclassification of the malignancy with the highest risk of stage 2 to 4. She had surgery, but if you look at this mass, it's not looking malignant, right? So histological diagnosis was a fibroma. So you can see that in this case, the ADNES model misclassified the benign lesion as malignant, probably because of the presence of ascites. Case 5 was a 60-year-old gram-multipara, 10 years postmenopausal, who presented with a 5-month history of abnormal uterine bleeding. He was non-diabetic, transfused 4 units due to abnormal uterine bleeding. So you can see the solid ovarian lesion, and look at the response of the uterus. You can look at the thick endometrium in a 60-year-old. No wonder she had abnormal uterine bleeding that necessitated 4 units to be transfused. So we imputed this information into the ADNES model. You can see the risk of malignancy was 6.4%, and the subclassification favors stage 2 to 4. You have surgery, diagnosis, adult granulosal cell tumor. Now, this is a consensus statement from the European Society of Gynecological Oncology, ISOC, Iota, and the European Society of Gynecological Endoscopy on how to manage adnexal lesions using the traffic light approach. So if the risk is less than 1%, as seen in previous slides, it's almost certainly benign. So if asymptomatic, conservative management, follow up in 3, 6 to 12 months. If the risk is between 1 to 10%, it's considered low risk for malignancy, then surgical management in general gynecological unit is appropriate. But when you have intermediate risks of malignancy, that is risks from 10 to less than 50% or greater than 50%, is referral to specialized gynecology oncology unit. Now, these 5 patients we've described have this risk of malignancy. You can see all more than 50%. So they're high risk, and ideally they're supposed to be referred to specialized gynecological oncology center. But of course, we manage all these patients. Now look at this case 2, where I imputed different variables, one without acoustic shadow and the other with acoustic shadow, and you can see the difference in risks. So it's essentially important to know the Iota terms, definition, and how to properly assess lesions so that the patients can be managed properly. Now, the ORAD's ultrasound risk certification and management system gives us not just the risks and the scores, but also how to manage patients depending on their menopausal status. If it's less than 1% risk, it's management, low risk, intermediate risk, and high risk patients are managed based on their menopausal status. That is the addition of ORAs to the Iota model. Now let's look at a few pitfalls. Now, how will you impute this into the ADNES model? More than 10 locules? Is it a solid structure? This is not an ovarian lesion. This is a case of suspected female genital tract tuberculosis. This is thickened peritoneum, what others call peritoneal blanket, and these are loculations of pus, and this is thick pus. How did you know that? Look at my needle here, trying to aspirate, and here I obtain yellow colored fluid, but here was actually frank pus. 3 months after antituberculosis treatment, look at the ovary, look at the residual lesion. Patient has already completed treatment and is doing well. So look at this lesion taking up color, but you can see these areas do not take up color. Why? Because this is not a papillary projection. You see that? The septae have taken up color, but this structure has not taken up color. Live tissue will take up color with the appropriate settings. This is a still image. You can see the multiple locules and the variations in the content of the cyst. Here you can see clear content. Here you can see this mucous block not arising from the cyst wall. Here you can see same cysts, different echogenesis. Here is more of low level echoes, and you can see this hyperechoic area here. This is typical of a mucinous tumor, and histology confirmed there's a mucinous carcinoma. Okay, here you see the different colors here, and look at the mucin content. This is a case of dermoid cyst or microcystic teratoma. This dermoid ball is not a solid lesion and should not be considered as a solid lesion. If this is considered as a solid lesion, this will be like 2 papillary projections imputed into the acetate muscle. This is not a solid lesion, and therefore this is a unilocular cyst. Of course, if you apply 3D, you may be even confused further that this looks like solid tissues, but they are not. Now, when we talk about acoustic shadows, again, we are making reference to the shadow that emanates from the substance of the lesion, not these ones, not edge shadowing, but shadowing that emanates from the substance of the lesion. Now, this is not a papillary projection, but a blood clot in a case of spontaneous severe ovarian hyperstimulation syndrome. Why do I think this is blood clot? You can see it's moving when applying proper pressure. Look at it. So solid tissue will not move. And again, when you apply color, the septae will take up color, but this content within the cyst will not take up color because it is not live tissue. So let's not mistake this for papillary projection and include it in the next model. Now, these are true papillary projections. But how many papillary projections do we have here? You see this? In a 20-year-old, unfortunately with a high-grade papillary cirrhosis, cystic carcinoma at 20 years. Just completed secondary school, planning to get married, and then this finding, quite depressing. So this is the specimen. Now, look at this and this. So, if you look at the indentation here, it's not up to 50%. So this is considered as one papillary projection and a second one. And look at the live specimen. Yeah, so 1, 2. So we don't have 1, 2, 3, 4 papillary projections here. No, what we have here is 1, 2, 1, 2 papillary projections. So here again, one can see this measurement here, measuring 0.84 centimeters, which is more than 3 millimeters. So is this a papillary projection or not? You see that? It moves on applying proper pressure. So this is not a papillary projection. You want to confirm it? Apply color. You can see it has not taken up color. So this is mucus block, no papillary projection. Of course, it turned out to be a mucinous cyst adenoma. You can see the typical honeycomb nodule. There's a saying that it is what the heart knows that the eye can see. So it's important for us to know the terms, definitions, and how to measure nasal lesions to properly use the Iota models to be able to differentiate between benign and malignant lesions. So our take-home message is that a two-step strategy is suitable for clinical use. Thank you very much for listening.